Okay, good afternoon and welcome to today's lunchtime lecture. I'm Professor Paul McMillan. I'm one of the lunchtime lecture committee and I'm your host for today. So if you could first make sure that you switch off your phones so that we don't interrupt the lecturer. Then a welcome to any audience members who are viewing us online. We're accepting Twitter feeds and also contacts via Slido. And so the Twitter feed is given on the screen here. And the event code for Slido is 5586. Our speaker today is Dr. Anita Berlin from the UCL Primary Care and Population Health Unit. And today she's going to be telling us about migrants and healthcare. So thank you. Bye.
Hello. As the President said, my name is Anita Berlin. I'm a senior lecturer here at UCL, but I've also for 20 years been a GP in North London. And I'd like to start with a story. Miriam is in her early 20s. About a year ago, she escaped from the barracks into which she'd been conscripted in the African country of war. She had been regularly beaten and abused. She managed to get over the border into Libya, across the sea, and into Italy. In Italy, she slept in parks and begged. And one night she was raped by a gang of men. Undeterred, she continued on a journey back to Calais with the hope of reaching London, eventually, where she was going to seek out an old friend. From Calais, by sheer determination, she managed to smuggle her way to the UK. Is it on? Is that better? Okay. Yeah, that's better. Sorry. So Miriam has now arrived in London, but there's no old friend. And she's sleeping on a park bench, and after 3 or 4 days of no food and little to drink, she collapses in front of a church. And she's taken in by one of the parishioners, and the parish takes responsibility for her for a little while. They try and register her with a GP. She's not very well. They try 2 practices. By now she's 29 weeks pregnant, and they learn about the Doctors of the World clinic in Bethnal Green, where they take her. And there they begin the process of the social and legal support for the asylum claim, and they refer her to hospital for her chest infection and her antenatal care. So I'd like to leave Miriam's story there for a moment, because I want to use that as the context or to build the context for some teaching that we do here at UCL under the banner of the Global is Local. About 2 years ago, we realized that it was in urgent need of updating. And so, for the purpose of this lecture, I'm going to actually spend quite a bit of time looking at the context, the way in which 2 crises have been framed, the NHS and migrants, look at the policy responses to these, some of the facts that underpin the current situation in order to build a case for what we did in the teaching, and pose to you some questions about what more we could do. And I'm going to interweave 3 case studies into my lecture, which are the ones we used in our teaching. But of course, you must bear in mind these are composites. Names have changed, details have changed in order to protect people's identity. So in order to look at context, I think it's very important for us to realize that one of our greatest challenges was how to teach a topic that has become highly politicized. So, to introduce the idea of framing. Framing and frame analysis is used in the social sciences and in media studies extensively. And we all use frames. Frames are structures which we use to hold and shape our view of the world. They are ways of communicating predetermined messages. Individuals use them, Organisations use them, social groups use them, and they're very commonly seen reduced into logos and slogans. They are used to inspire, to motivate, like a call to arms, but they're also used to manipulate, to divide and to deliberately deceive. And so we all use frames in order to help us define issues or problems, to assign causal or responsible link, to make moral judgments, and then align our moral judgments to any remedies that we think would be appropriate. So I want to apply the idea of frames to the two key concepts here, which is the NHS and its relationship with migrants. So I'm going to start with the NHS. So the NHS is considered to be a model of universal health coverage, which by definition is free at the point of delivery without financial risk to the users. And so one of the main frames of the NHS is one of this positive universal health care system, which is recognised that while we may have an unequal society here in the UK, it's a highly equitable way of delivering healthcare. And all the countries of the United Nations have now signed up to promoting universal health coverage as a goal within the Sustainable Development Goals. But we see an emerging new frame for the NHS, which is an organisation in crisis, a service on its knees that is no longer affordable. Let's turn to the framing of migrants. So this is data from a study by Crawley and colleagues in Coventry, published recently, where they looked at all the printed press between January and May 2015 in the run-up to the 2015 general election. And they identified three clear frames. The benefits frame, whereby migrants are seen as contributing to society and to the workforce. The threat or the villainous frame, where migrants are challenging our economy, our jobs, and threatening our security. And the victims frame, a sort of voiceless, semi-voiceless group who are victims of inequality, discrimination, and worthy of our support and compassion. So the relationship between the NHS and migrants is long and intimate. And it is usual to frame, or has been until recently, to frame the relationship as a very positive one, as a benefit, largely through, as we see here, a diverse it's sustained through a diverse workforce. And we see this very inspiring image from the 2012 Olympics opening ceremony. Preparing for this lecture, I did a little bit of research, simple research myself, using a tool called Google Trends, where I looked at internet searches for immigration, UK immigration, and migrant crisis over the last 5 years. And you can see that there are broadly 4 peaks. The first peak corresponds with the 2015 election, which is the Crawley's work. The second peak was at the beginning of September 2015. Happened actually to be the day before our new teaching began. And none of you will have forgotten, I think, this image of a child washed up on a Turkish beach. And here we see a very clear framing of a migrant as a victim, impossible not to feel compassion, but very much a victim on a foreign shore. The third peak and the little peaks afterwards all coincide with the Brexit referendum and the fallout thereof. And the final peak was at the very end of October this year, which coincided with the dismantling of the migrant camp in Calais. And on the day that most of the newspapers ran the burning of the camps as a front page story, the Express chose to lead with this, the Sunday Express chose to lead with this story. Now, what I need to say here is it's not possible to work in the NHS in London for 20 years without knowing that people come to the UK to take advantage of our universal service. And there are plenty of expats who come from places like Torremolinos once a year, asking for tests and hospital referrals. And there's no doubt that they are package tours arranged in Nigeria for women to go either to the States or come to the UK in the hope of delivering their babies and perhaps even with the promise of getting a British passport for their children. The point about this article is not whether it's true, it's the fact that it was chosen to lead on a day where there was other stories about migration, and that it's not a new story, that is recycled, and the same story has been run either by the Express or the Mail regularly since 2012. So this is the context in which we do our teaching and in which Miriam is trying to find healthcare, which is where there's a reframing of the relationship between the migrant and the NHS from a benefit in terms of a diverse workforce to a migrant patient who is abusing the system and is directly responsible in some way, some large way, for contributing to the crisis. So we have a crisis on a crisis, and we now have this causal relationship. In addition to that, we need to take into account in our teaching a policy environment and the way in which policy towards migrants and healthcare have changed. And so policymakers are always at pains to address the mood, the popular mood with regard to both migrants and the NHS. And both topics have featured in the top 3 issues in popular surveys way back into the 1980s. So the fact that migrants feature is not new, but it's the moving the concept of the migrant or the framing of the migrant from a social problem issue of cohesion to one of a political problem that needs a political solution. And so, and one of the challenges for policymakers is to have a constraining approach to migration, but one that does not actually constrain. This is one of the interesting things that will happen following Brexit, constrain access to a global workforce for the benefit. So 2 key policy areas that were introduced with changes to the Immigration Act in 2014-15 were firstly the NHS Overseas Migrant Cost Recovery Scheme, which applies currently only to hospitals, and the Immigration Health Surcharge, which is £200. It's paid for now prospectively at the point at which people apply for a visa, either to come to the UK to work or for students who are going to be here for more than 6 months. And one of the key things here is to recognise that although this was discussed, GP services remain free and without any restriction to anybody living in the UK. So we have to ask ourselves, if we go back to Miriam, why could she not access a GP? Well, what we have to remember, first of all, is that when she was taken by the good people of the church to the GP practice, she was at the time an undocumented migrant. She hadn't begun her journey as an asylum seeker. She had no papers. And a very substantial proportion of undocumented migrants living in London never attempt to access healthcare because of fears of being reported to the Home Office, detention, and possibly subsequent deportation. The Doctors of the World did a study recently where they identified that of those who do approach GP surgeries, about 60% of them are denied registration, primarily because they're asked for documents that they don't have, even though this is actually not a requirement in the guidance from the NHS. And secondly, because of a number of cultural and languages barriers. Going back briefly to the cost recovery scheme, it wasn't introduced without any thought. There are a number of clinical exemptions, which I won't go through in detail. However, this is clearly a focus for teaching for senior medical students prior to them becoming junior doctors. But what I would stress is that there is considerable amount of clinical judgment required in interpreting these exemptions. Most importantly, if your condition does not appear in the list of exemptions, you will be asked to guarantee that you can pay prior to your treatment beginning. However, if your condition is deemed urgent or immediately necessary, which are clinical definitions, your treatment cannot be delayed until such a time that you can guarantee that you can provide the funds. So it's very important that students understand how those clinical decisions are made. There are also a number of groups who are exempted, those who are in the process of seeking asylum, refugees with leave to remain, survivors of trafficking, slavery, FGM, and migrants who've arrived due to domestic violence, who are all in the national service framework for national referral mechanism, rather, for migrants and modern-day slavery. However, again, you should note that that extends only for 45 days until the individuals either decide to be repatriated or make an asylum claim. And finally, there's this very small number of refused asylum seekers who are exempted, but it is a tiny number, and what you should also note is that 50% of all asylum claims in the UK are turned down. One of the important things also for students to understand is that, particularly within the groups of those who've been trafficked or who are victims of slavery, is that they may access healthcare, but they may come with their masters, and they may not often be able to disclose that they have been that they are held under duress. They may not have a lot of insight into it, and careful history taking is actually a very important part of understanding the clinician's role. Just some very quick figures. If this is the predicted total spend for the NHS for this year, £117 billion, this large orange bubble, then the target for the recovery scheme was less than 0.5% at 500 million. And it has already managed to generate 164 from the surcharge. However, the tiny little green bubble is what's actually been recouped from treatment costs. 250 million was billed, only 125 million has been recouped. And the National Audit Office, from where I've got these figures, predicted that 50% that's not been repaid will never be repaid because the bills have been given to people who are never going to be in a position to repay them. The other thing about this system, which the Audit Office notes, is that it requires an enormous machinery to introduce charging and billing into a service that has never had charging and billing. And therefore it requires every acute hospital to employ an overseas visitor manager, to train them, and to make sure that the paperwork and the bureaucracy will flow so that the billing can take place, which adds considerably. So by this time, you're probably beginning also to think that I'm beginning to sort of muddle up different groups of migrants here. But let me try and unpack that a little bit. So we've talked about the voluntary migrants, people who come here either as students or to work, who have visas and extant passports. We also talked about those who are forcibly displaced, who may be displaced through conflict, environmental change, border changes sometimes, violations of their human rights, who come under these categories that I've talked of before. But there's a growing number and a grey area between the recognised forced displaced and those who are somewhere in between. They're citizens of nowhere. A large group of destitute overstayers, perhaps students who come on a visa, who find that their country now is war-torn, they can't return, exploited workers who've come with poor work arrangements, whose passports or visas are not renewed by their workers. In Doctors of the World clinics, the largest single group that attends are Filipinos who have been brought on domestic visas and who are let go by their employers and have no passports or visas. The rejected asylum seekers who still fear returning home also are in this undocumented group. And these are essentially people who are stateless. And so where you see now that people, their entitlement to patienthood is through a passport, we have to wonder what happens to people who are citizens of nowhere. Just to put that on a global scale, 2015 saw the biggest movement of people through displacement ever. 65 million largely displaced internally, 21 million recognised by the UNHCR as refugees, and this growing group of people who are stateless, the citizens of nowhere. And so to put that in context in London, if we think about the way this scheme was set up, there are, in theory, provision for overseas visitors and students and for migrant workers. There also is provision for asylum seekers, as long as they're not refused, refugees, and survivors of trafficking and modern-day slavery. But I think you will agree it is easy to see how anybody in any of those groups can slide into the undocumented group and become potentially excluded from a health service that is, in its inception, was intended to be universal. And so what has happened over the years, and the UK has in the past had a considerable reputation in taking in refugees and asylum seekers, is that there is considerable expertise being developed by NGOs such as Doctors of the World, Helen Bamber, and Freedom from Tortures, amongst others. And this expertise has been in recognising torture and the scars of trafficking, both physical and psychological, and particular expertise in mental health in areas such as PTSD. And that expertise has helped to support people like myself in mainstream public services. However, as we see the NHS contract, we see the need for these NGOs to start actually providing care and filling gaps. And studies in Germany and in the UK recently have argued that there is a very strong economic and health case for treating proactively both forced migrants and the undocumented migrants, and that delays in treatment pose a risk to our public health, to all of us, but also increase social inequalities and health outcomes by leading to preventable illnesses and premature death. And so we go back to Miriam. So Miriam now has attended 3 antenatal appointments. She was found to have TB, which is being treated. And as the midwife and the obstetrician leave, the overseas visitor manager arrives. And she has just been told that she has a condition called placenta previa, which will require her to have a caesarean section, and there may be some complications. And the overseas visitor manager presents her with this price list and indicates the figure at the bottom, which is for people who have caesarean sections with complications, and tells her that she will be issued with an invoice for £9,700 once the baby is born. And she's devastated. She's heartbroken. She doesn't understand why this has happened. And it turns out that there's been some very poor record keeping and communication in the hospital, and a health advocate intervenes on her behalf. And so to summarise, there's a double crisis in which migrants are now being framed as a threat to the NHS, and there's a policy response which requires a significant bureaucracy, sets targets which are low and not being met, is poorly understood by clinicians, and it's actively deterring people who might develop high health needs, and puts all of us at risk. So you don't particularly want to sit next to, or your child sit next to, somebody with open TB. So where does this fit into medical education? So it was easy in medical education when we were preparing people to work for a monopoly employer with a universally free access. Now things are more complicated. Education is taking place in a new context, and there are new service models emerging. And one of our particular challenges, I think, is how do we impress upon our future students that they are the architects of tomorrow's health system. They are going to be designing and stewarding the system that you and your parents and your children or grandchildren are going to be using. And one of the questions they need to ask themselves is, this is a quote from Gorik Ooms, who is a specialist in migrant law, who says, in an increasingly mobile world, how are we going to provide health coverage on the basis of where we are living in terms of our human rights and not just where we are in terms of our citizens' rights? So I suppose that question I just briefly posed to you, if you're reflecting on Miriam's case, how do you think we should frame teaching for tomorrow's doctors? Well, we met with Doctors of the World, who have an education officer, and we posed ourselves this question: why is good access to healthcare for vulnerable migrants important? And we considered that there was a duty of care to individual patients to at least follow the letter of the policies, that there was also a wider public health interest, and there was also an important role in not adding to health inequalities. We also considered those issues related to human rights and citizenship, and we discussed whether to draw attention to the mechanics of the cost recovery scheme. What we actually decided to do was focus on the public health and the health inequalities issues by looking at individual healthcare duties under the banner of our global is local theme. And so what we did is we worked with the outside agencies, in our case, Helen Bamber Foundation and Doctors of the World, who gave inspiring and informative lectures, and then we broke students into small groups where we worked our way through the 3 clinical cases, looking at the evidence about migrant health and outcomes, and appealing to some of the human skills in relation to communication, so trying to engage them, their heads and their hearts in the learning about the cases. And so what we actually were doing, I suppose, is following a competency model where you ensure that the students understand at least the key exemptions, the clinical aspects of the cost recovery scheme, that they can then apply those using their clinical judgment to case studies. And so perhaps you could say, job done. To quote Lincoln, if you give people the truth, they can be depended on to meet a national crisis. And the great point is that you have to bring them the real facts. So the students have the facts, but the question is that enough? So let me introduce Jay. So Jay was a member of a student opposition group in an Asian country. He was arrested, tortured, and held in prison in shackles for 2 months. He was released suddenly, and his parents managed to get him out of the country onto a flight to London, and he was well briefed, so he presented himself to an immigration officer when he arrived, and he was interviewed, and he was told to report for a full asylum screening interview a week or so later. And he was met by an elderly aunt that his parents had contacted at the airport, who was so alarmed by his condition, took him to immediately to an A&E department where he was seen after a wait by a very kindly junior doctor who took a lot of interest in him and took his history, examined him carefully, found that he had long wounds consistent with burns, and he had infected wounds around his ankles, gave him antibiotics, told him he didn't need to come into hospital, but he needed also painkillers, to register with a GP, to be referred for follow-up and further care. Jay and his aunt leave. Doctor writes his notes, and as he goes into the waiting room, he sees Jay being led away by the police, followed by distraught aunt. And he finds out later that the receptionist had called the police, believing it was her civic duty to report an illegal migrant. Later, as Jay told the story to the doctor who was doing his medico-legal report for his asylum claim, he said that the 4 hours he spent being interrogated in London was almost more traumatic than the experience of being 2 months in a prison at home, because it was so unexpected. And he thought he'd arrived in a place of safety where he could trust people in authority. And some interesting work done recently at the University of East London shows that the current climate and the policy changes are turning a lot of ordinary people in public-facing roles into everyday border guards. And so this raises questions really about how students going into the professions may understand what is happening around them. And a study recently published in Stanford showed that students using the internet, searching for news and for studying, were unable to make a lot of sense of what they were reading, particularly in topics that were politically charged. And this study was actually done before the recent issues surrounding, obviously, the presidential elections. And so they were susceptible to bias. They were unable, or they didn't regularly check for credibility, and they were not good at distinguishing, and we know that they were not as good at distinguishing false news from facts. So what I would suggest, and what we will be looking at in our teaching, is moving to introduce a more transformative approach which promotes critical thinking in our students and get them to consider outside the box a bit more and to develop themselves as advocates, not just for people like Jay and Miriam, but also for the health system, that they are going to have to advocate for what type of NHS or service that follows that. That's it. So those are the 2 areas that we would want to cover. But I would like to just say a little bit, just to end with talking about something to do with my own research into institutions and how they frame their own missions. So universities have 2 key and core missions. One is to generate knowledge through research, and the other is to share knowledge through education. But they also have choices that they can make about how they frame themselves in relation to the outside world. And so a question might be, what happens in a university that frames itself to have a global mission, and does that global mission have a local interpretation, a potential local interpretation? And so I'd like to tell you just very briefly the last story, which is about Suki. When Suki arrived at Doctors World Clinic, she was 18. She had a serious kidney infection. She'd been working in a takeaway, and one of the customers had brought her to the clinic, despite the protests of her manager. Turns out that she had been in the country for 4 years. She hardly spoke any English. She didn't know her address. She had no mobile phone, no cash, no passport. And she had actually been trafficked into a massage parlour. Her grandmother, thinking that she was actually coming to the UK to be fostered, had paid a gangmaster. Anyway, Suki, with the help of the Salvation Army that holds the contract for looking after trafficked young people, managed to get to school. In a year, she learnt English. She passed 6 GCSEs, 3 sciences, and maths included, and all she wanted to do was go to university, and she hoped that she'd become a pharmacist like her late grandfather. And so my reflection is, what might a global university be able to do locally for somebody displaced and who has no social capital, who doesn't know how to get into a university, has no financial backup, could not raise the funds while she's waiting for her asylum claim, which may take years. And so, just to share with you, there is a loose alliance under the banner of Refuge in a Moving World, which is organised by an impressive woman who did a lunchtime lecture about a month ago, Elena Fidian Kashmir, that are looking at different campaigning aspects, collaborations with organisations such as CARA that support refugee academics, harness donations, etc., increase access and improve information. And so I leave you with this thought, which is that some universities, including all the Scottish universities, have actually signed up to clear policies regarding supporting potential migrant students. UCL as yet does not have a formal policy, and maybe they are concerned that their mission will be reframed as Bristol's was in the summer when they announced a scholarship program that they were giving out free. I love the use of capitals in these things. Free degrees at top universities while Britain's amassed 2 deaths, and then the refugees in capitals who are taking their places. And I think the final quote goes to Dante, which is a question that I think I asked myself as an academic in my teaching, perhaps as a doctor too, which is to reflect on the darkest places in hell reserved to those of us who remain neutral in the time of a moral crisis. So thank you very much. And with thanks to my colleagues.
Thank you, Anita, for a very thoughtful and thought-provoking presentation. And please, we do have some time for some questions and comments from the audience here. So, gentlemen here. So, I think that we should have...
Sorry.
Okay. So, you need to use the microphone. It's the gentleman in the grey.
Hi, firstly, thanks a lot for the talk. It was really, really interesting. But what struck me was amongst all of that complicated, fascinating picture that you presented, one very practical problem that seemed to emerge was that individuals weren't able to access healthcare essentially because of their migrant status, but it was because they were being asked for documents they didn't have.
Yeah.
I just saw that as a really simple problem which could be solved, but doesn't seem to be being solved. Can GPs not have it in there?
It's bad organisational practice, and it's not properly promoted. And so, for example, one option would be that GP practices are subjected to regular CQC inspections, and it should be part of that to ensure that reception staff know that there is not a legal requirement to ask for proof of address or a passport in order to register. And in fact, homeless people should be registered using the practice address as their postal address if they have no postal address. So it can be got round. And there's 60% who don't register, but there's a good news that 40% do register, and they understand that responsibility. And there's some practices who go out of their way to register homeless people. Yeah, it's good. Very good point.
Do we have another question from the lecture theatre? The lady here. So
Thank you for your presentation. The diagram showing the subcharge, why is it that they still ask money from people who can't pay? And like, if you said that so much of it isn't paid back, why isn't the message still being received? It's futile.
Well, it was only introduced in a year ago. So they're still running it. The overseas visitor managers are all new to their jobs, but there is no exclusion. You're not exempted because you can't pay. If you don't have one of those conditions, and then you have to pay. If you're not in one of those recognised groups, or if you don't have one of those conditions, in other words, if you're undocumented and you can't demonstrate that you are entitled, that you have entitlement, you have to pay or leave the hospital.
Thank you.
So people have the treatment, especially the immediately necessary and the urgent treatment, and they're billed afterwards. Can you see? It's a sort of vicious circle. And one of the problems is that on the bottom of the invoices it says, if you do not pay within, and there's a specific time period, this will be notified to the Home Office. Yeah? I mean, what a deterrent is that? Yeah?
Well, I've got 2 questions. The first one is how climate change will rise this challenge, and second, how a wider social rights approach to policy is needed to bring a better environment to tackle this issue.
Well, both. I think we don't know. And one of the problems with displacement due to climate change is that people are sort of simply moving out of uninhabitable areas. And that doesn't have the same sort of provable, and don't forget. So, for example, in order to demonstrate torture, the definitions of what is torture have been changed repeatedly over the last decade or so to make the definition more and more narrow. And so how do we actually say people are actually displaced and are in need of shelter because of climate change? It's going to become extremely complicated. We're already seeing water, people migrating through lack of water. So that is going to become increasingly so. Why don't we use a social rights model? Well, in a way, that was what underpinned. And what we have to remember, I think is most interesting, is talking to my 95-year-old father who said to me, don't forget that the Labour government that came in after the war came in on a popular vote. It was a popular vote against the officer classes by the troops who had been conscripted into the government. And they generated a completely social program. The whole welfare state was based on actually a popular uprising. So one of the questions may be is if we actually, this is maybe the most optimistic, that we might get actually a concern for social rights emerging out of our current more negative popular framing of social relations. Does that answer your question a bit? It has to be wanted. It's very hard to promote it directly.
I'm sorry, but I think we need to close now because there is another class coming in. So thank you all very much for attending today and to our audience online. And if you remember that there is another lunchtime lecture this next Tuesday, okay? And if you could remember to fill in the evaluation form on your way out. Thank you very much, and thank you.